Good evening, everyone, and thank you all for being here tonight. My name is Kylie Hopkins, and I'm a fourth-year nursing student at McMaster University. I am privileged to be both a Wilson Leaders Scholar and a graduate of the Health Leadership Academy's Emerging Health Leaders program. I am very excited to hear from our featured panelists, Des Gorman and Danielle Frechette tonight, and can vouch for both their incredible experiences and innovative thinking in healthcare, as the Wilson leaders had the opportunity to speak with both panelists this afternoon. I am also aware of the responsibility we have to ensure our leadership abilities are up to the demands of our healthcare challenges. It is great to see each and every one of you here tonight to be a part of the process of making ourselves aware, not just of our challenges, but also of potential solutions, in committing to the Think Tank participatory event. Of course, we can do so much to prepare ourselves. There are opportunities for students among us to develop our leadership skills. One of the opportunities is the Wilson Leaders Scholar Award. Students hold this award for the last 2 years of their undergrad and has taught me a more innovative way of thinking and approaching my potential as a future healthcare leader. Another is the Emerging Health Leaders program. During the 2-week program, I learned more about my leadership style and skills within the context of healthcare. It was an immersive experience, and I'm still in touch with many of my fellow participants. One of the best things about these opportunities, these leadership development opportunities, is the chance to meet with like-minded, energetic, interested thinkers with areas of strength and interests that different from your own. Tonight, I expect we'll get a window into that kind of experience. We'll sometimes agree, we'll sometimes disagree, and come out with a better understanding of how to move forward. Thank you.
Hi, welcome. Small but very accomplished group. My name is Del Harnish. I'm the co-director of the Michael G. DeGroote Health Leadership Academy and an associate dean in the Faculty of Health Sciences. 2 years ago, Michael DeGroote provided a very generous donation to support the development of the Health Leadership Academy. And he did that in the context of the vision of the deans at the time, John Kelton and Len Waverman. The vision was to provide an opportunity for young people to start thinking about leadership and to develop a way of thinking about it in terms of future needs. The Academy began by developing leadership programming for young people. Those were the emerging leaders, and has now started to make connections with other programming, still centered on thinking about leadership skills and knowledge. This fall, a cohort of health practitioners will enter the new DeGroote Executive MBA and will think about digital transformation in the context of health. So that'll be quite exciting. All of this, of course, links to the Wilson Leadership program in very specific ways, because it too supports young people as they begin their leadership journeys. So Danielle Frechette is one of our guest speakers tonight. Danielle is at this table. She is the Executive Director of the Office of Health Systems Innovation and External Relations at the Royal College of Physicians and Surgeons of Canada. With more than 25 years of experience in the field of social policy, she's guided the development of the Royal College's health policy and governance functions since the early 1990s. She did at the University of Ottawa an Arts and Communications degree, and then I personally like that she went to my alma mater at Queen's to do a master's in public administration. Her governance-related interests center on innovations that optimize decision-making and accountability. Her health policy-related research interests focus on numerous aspects of human resources for health and healthcare system effectiveness, efficiency, and equity. She has a very rich experience and perspective in navigating these issues with a wide variety of constituencies, including government. If you have time, and you should make time, you might look at her appearance before the Parliamentary Health Committee in 2014 for a little insight into some of the challenges of working with some of the sectors she works with, and that's a public record. She intends to address for us tonight the perspective of health professionals on innovative health systems. And our second guest is Professor Des Gorman, who's at the same table. He's a professor of medicine and associate dean of the Faculty of Medical and Health Sciences at the University of Auckland. If you've not been to New Zealand, please go. He holds a medical degree from the University of Auckland, as well as a PhD from the University of Sydney. His primary interests are health system design and funding, health workforce planning and development, and from a clinical perspective, brain injury, diving medicine, occupational medicine, and toxicology. He has more than 250 publications. If you have an opportunity, you might read and think about one of his publications, Medical Graduates, Truthful and Useful Analytics with Big Data, and The Art of Persuasion. That was in the December issue of Academic Medicine. It will certainly complicate your world a little if you read it, and more, it will help you understand the dimensions of leadership that Dr. Gorman espouses. He's going to speak about comparative analysis of health systems. The format for the evening is actually pretty straightforward. Our distinguished guests will have about 20 minutes each to speak, and then this will be followed by 15 minutes of questions. And then the Health Leadership Academy Program Manager, Amanda Colizeo, will take us through a little bit of an exercise to think about the future of health. Should also try and make a little bit of time tonight to speak to each of the guest speakers. I had a very small opportunity before we started tonight, and I'm still laughing. So there's lots of interesting things you can chat about. Welcome.
Kia ora tātou. As you can see, I've actually got some slides, which is unusual for me. Though one of the things I'm going to ask you to do for me is give me a title for this talk. I was fiddling with it on my phone on the way from Muscat to Dubai, then on to here. And so I was so impressed by the fiddling, I thought, well, I was inflicted on you guys. So here it is, as yet untitled. I've got 3 hypotheses to put to you first of all, then I'll wander you through a few concepts, and I want to leave you with a whole range of questions. The first hypothesis is that the transformation of healthcare has been slowed and or stalled by an interaction of powerful forces. The reason why I say that is that there are 3 profoundly recidivist industries in terms of innovation. Health is one, the legal system's another, and education's a third. And in fact, if you look at our health core operating model in healthcare, it made sense in 1850. It certainly does not make sense in 2018. And in that context, it's worth saying, what are these powerful forces? And I'm more than happy to discuss them with you later on, because there's about 8 or 9 major forces that I identify which collectively have blunted innovation. Now, it's also attractive to argue that education, law, and health have in common a dominating professional power elite in the case of health doctors who frankly have no interest in things changing away from their self-interest. So it may be that that is a major commonality. The second hypothesis is that in most OECD countries, a tipping point has been reached and profound healthcare transformation is inevitable. And that tipping point is fitness for purpose, affordability and sustainability. Of the 35 health systems that I've reviewed, none of them are sustainable, none of them are affordable, and I'd argue that almost none of them are fit for purpose generically. Now, what you have to ask me is how we've got to the point where we've got such unsustainable, unaffordable health systems. And that goes back to that first hypothesis that in any other context, these things would have been disrupted a long time ago, but they haven't. The third hypothesis is that although patient-centred healthcare has survived as the cornerstone of most health systems' operating models for centuries. Now, what I mean by patient-centred, a lot of people will say to me, the ambition is to have patient-centred healthcare. In my view, healthcare has been patient-centred since Hippocrates. It's always been based on patients. It's not patient-owned, it's not patient-managed, it's not patient-determined, but it's certainly patient-centred. The core operating model in healthcare in Canada and in most countries is reactive. Someone has a health issue and presents. It's transactional, so it's reactive and transactional, and it's hospital-based and doctor-led. Now, it's rapidly being replaced by what is best described as participatory healthcare. And this model of care will in turn evolve into an era of what will be predominantly self-management and increasingly personalised healthcare. The context of transactional reactive healthcare, hospital-based, doctor-led, again, certainly makes sense in an 1850 environment of communicable acute diseases. But in a lifetime of long-term chronic disease and chronic morbidities, to base your health system around doctors and hospitals makes no sense whatsoever in terms of where you'd get to if you thought this from a blank sheet of paper. So let's have a look at this, how it was not that long ago. When I arrived at first time after I graduated in 1977 and arrived at Heathrow in 1978, I took a taxi into the city and I paid the taxi driver because I was paying him for his knowledge, and he passed an exam called the knowledge, and they still pass an exam called the knowledge. So the value proposition was that I paid him because he owned the knowledge, and that he then delivered me to where I wanted to go on the basis of that knowledge. So when I arrive at Heathrow in a couple of weeks' time, what am I paying for? He no longer owns the knowledge. I have the same access to knowledge, that knowledge. In fact, I have better access to knowledge. My little phone will tell me where the traffic congestion is, where the roadworks are. So what am I paying for? What is the value proposition in a world where I have access to the same information that he does in real time and in an assimilable format? If what I'm paying for is someone to drive the taxi, then with all due respect, in 2025, I don't even need him to do that because it's going to be autonomous. And the question, of course, you can hear me about to put to you is how valid is this analogy in terms of the transition from the consultative period of medicine, where I, as a physician, my interest is in brain injuries, was a repository of knowledge and people came to me in a reactive fashion for me to dispense that knowledge in a way which helped them with the problem they presented with, to an environment where they have the same knowledge access that I do, and they have access to a whole range of artificial intelligent processes. So the question is, the dodo is certainly extinct. Bank tellers have gone with the virtualisation of banking. London taxi drivers have a diminishing value proposition, and what else? So let's look at this London taxi analogy, the London taxi driver and the knowledge, the consultative era of medicine, which has been, as I say, in terms of the core operating model, spectacularly recidivist, and survived despite a complete change in the burden of illness. It's one of the few areas where the model, or service model, has persisted despite a complete and radical change in the conditions that we're providing those services for. As we move now into participatory healthcare, and this is a term that's not my term, it actually, the first I saw it was actually produced, believe it or not, by Ernst & Young, but it's a very good description for a world in which people present with knowledge or with information or with sources of information, and increasingly our job is to help them manage that information, to be able to assimilate that information, to be able to use that information, to provide some utility around that information. But the question is, nevertheless, in the same way, what is the value proposition for the London taxi driver? It is, what is the value proposition for healthcare providers? And clearly some providers are going to be more threatened by this than others. And then finally, of course, as we move into the autonomous taxi, this era that we're going to emerge into, which is around personalised healthcare and self-management, becomes a major issue in terms of how do the health professions redefine their value proposition. Bearing in mind the background to this, I've been recently working in one of your provinces where they are spending $5,000 per person per annum on healthcare. Well, that was all well and good when that particular province was earning $100 a barrel of oil. But $5,000 per person per annum for healthcare is completely and absolutely unaffordable. You as a country spend over more than $4,000 per person per annum, and yet your healthcare, according to the Commonwealth Fund, is second to worst compared to the US. And that's not a good place to be, bearing in mind that the US does not have a health system. They've got a marketplace and you purchase health as a commodity. There are health systems in it, but it doesn't behave systemically. How do you spend $4,000 to $5,000 per person per annum and still end up with a system that fails to address most of the health needs of many parts of your community? The answer is you're applying a model which, with all due respect, belongs to the dodo and perhaps the London taxi driver. So here's some questions for you. How valid for healthcare providers is the London taxi driver analogy? And let me give you Auntie's story. Actually, this is a Maori woman. It's not an auntie. It's actually my grandmother. I'm the white sheep of our family. That little brown girl in her arms is one of my sisters who's now dead, and that good-looking, fair-headed kid with a bow tie looking sharp is me. And so this is a photograph of multiracial New Zealand with a honky hanging on to the brown woman's skirt. But Auntie's story in 2018, very common in Indigenous New Zealanders, poorly managed diabetes, frequent falls from hypoglycemia. Now this particular auntie I'm talking about, for her to get her insulin dose changed, took 4 months. There were 4 visits to see her family doctor. There was 1 visit to see a physician. There were 2 hospitalisations from falls, and there's 1 visit to a pharmacist. To get her insulin dose changed required all those transactions over all that period of time and with all that cost, including the hospitalisations for falls. Another version of Auntie's story is this. Auntie falls over, her watch sends a signal that she's fallen over, and a community health worker goes out to see her, downloads the biometrics from her watch, uploads it into the cloud, pricks her finger, does a series of spot tests, photographs them, uploads those to the cloud. And while they're waiting for the virtual team to produce a new treatment plan for Auntie, looks in the cupboards, has a chat to her about the food that's there, wanders across and has a conversation with a neighbour about the social services available to Auntie. And within an hour, that community health worker has a very insightful knowledge of Auntie and her circumstance, and a treatment plan from the virtual team is available and ready, and the change in medication's on its way from the robot pharmacist. The question is, and I mean, it's no point, it's a rhetorical question to say which of those 2 models of care is preferable. One took 1 hour, never left a home, no hospitalisations. The other one, with all due respect, is appalling. The irony of the appalling story is that that's commonplace. That's what's appalling about it. It's commonplace. What are the barriers to the second version of this story becoming business as usual? What's holding back? When we present this to some of our leadership scholars, they wander off worrying about the technology before they realise this technology has existed for a decade. It's got nothing to do with technology. This is about who regulates the virtual team, how do you fund the virtual team, and more worrying for my profession is, hang on, do we even have a place in the virtual team? What value do I as a physician add in a virtual team where I can embed, off the basis of the biometrics, artificial intelligence processes which arrive at an insulin profile, bearing in mind the management of diabetes is largely in the nursing paradigm? What are the barriers? The barriers are funding, regulation, and the patch protective behaviour of my guild. There's all sorts of things which we are seeing that can replace healthcare workers. The artificial intelligence capable Babylon health phone app, dispensing robots, compliance phone apps, which health psychologists run, which make a huge difference to hospitalisations of diabetics and patients with mental health issues by simply sending them texts to remind them to take their medicine and to have their blood test to make sure the levels have done real-time biological monitoring and concurrent artificial intelligence interpretation, automated laboratories and imaging suites, surgical robots, and so on and so on and so on. Now, I'm going to put some questions to you which clearly are chauvinist in the sense that they are really addressing the role of the doctor of the future. There are some professions that are going to be more threatened than others by this. Nurses will be far less threatened, as will midwives, because in a caring, hands-on role, they're far less vulnerable to this form of disruption. Pharmacists are hugely vulnerable, particularly those that largely make a living out of dispensing. Laboratory workers, medical science technology workers, there is huge vulnerability here. And I mean, and in fact, is this world I'm painting to you real? Well, last year, of the over 100 million member doctor contacts in primary care at Kaiser, 52% were virtual. More than half of the what would have been traditionally GP patient contacts last year were done virtually. Now, Kaiser's a monoculture, but when we get our scholars to tell us what proportion of primary care contacts which exist today on a doctor-patient interaction could be managed virtually with no loss of quality of outcome or experience, what proportion could be managed virtually, we end up with a cluster around 50% or a cluster around 80%. The 50% cluster is where people deconstruct the doctor's role. So this is what a doctor does. These are the things they could give up. That's a deconstruction. You end up saying half of what they do could be done virtually. The construction is when you say, no, it's going to start with a blank sheet of paper. What is it that only a doctor can do by virtue of their skills, knowledge and experience? What is it that only requires a doctor? And that's when you end up with an 80% virtualisation capacity. Is that real? All right, let me tell you, a friend of mine ran healthcare, primary care in Soweto for 4 million black people with 40 doctors. He ran primary care for Toronto with 40 doctors, and it was one of the top-ranked public health services in South Africa. You might say that's a low bar, but the point is, how did he do it? He said to the 40 doctors, actually any one time he only had 25 to 30, what is it that only you can do? And they said, well, we can differentiate people. We can turn the breathless person into a pneumonia or a heart failure or a pleural effusion or a pulmonary embolus. We are pretty good at that. We can make decisions when we don't know what's going on because we know what it isn't. We're pretty good at that. And we can manage complex biopsychosocial disease. He said, okay, boys and girls, that's all you're doing. The rest will be done by nurses, community health workers, and by a whole range of other health systems. So is this 50 to 80% virtualisation potential real? Well, of course, Kaiser's manifesting it. And in the case of that South African example I gave you, in fact, it may be a skinny estimate of what could be done in a different way. Of course, what we're not talking about here is getting rid of doctors the way bank tellers were dismissed. What we're talking about is where do we put them where they add value? Where do they operate where they add value? And I keep using that word value because it's the word that I want stuck in your heads. So here's some questions. In the context of the time and cost to train them and the cost to employ them, what value will doctors add as virtual mechanisms become more comprehensive, more accessible and designed for self-interpretation and self-management? Same sort of question, prefaced with a different suffix. What value will doctors add in a milieu of purpose-trained technicians and as robotics become cheaper and more dexterous? Next question, how well are medical students and doctors in training being prepared for the current participatory healthcare environment? When I was Dean of the Faculty of Medical and Health Sciences in Auckland, how much time did we devote to our medical students, our nursing students, our pharmacy students and so on, in teaching them to be educators or leaders? Absolutely none. Yet a participatory healthcare environment requires what fundamental skills? Leadership and being an educator. We're not preparing people for this participatory environment, let alone preparing them for an environment of increasing citizen self-management and personalised healthcare future. And here's often asked question, if the medical profession is to avoid the fate of the dodo, bank tellers and the probable fate of the London taxi driver, what does the profession need to do? Now look, there is 3 possible responses to this. The first is not going to happen. It hasn't happened since Hippocrates. This is not the way we practice medicine. We are simply not prepared to accept this sort of financially driven disruption. Let me tell you what happens to that sort of perspective. The tide of change will sweep over you and sweep you out to sea, and all we'll find on the beach is a pair of shoes. The second response is to say, I'm not sure, I'm going to stand back and just see what happens here. I'd remind you of Jean-Paul Sartre, who pointed out to us, you cannot choose not to choose, because not to choose actually is to choose the way things are. So to stand back and say, let's just see what happens, you're going to disappear over the horizon and we'll find your shoes. The third way is to say, we as health professionals have a leadership obligation and responsibility, and it's to take these emerging technologies and to shape them in a way which provides a healthcare system which addresses Don Berwick's triple aim. This is about care, health and cost. This is about how do we shape this emergent disruptive world into a world where people have better health experiences and better health outcomes from care. How do we shape it into a world where we have better population health and a healthy, productive community? And I should remind you that public health has its raison d'etre in macroeconomics. The Industrial Revolution is the reason why we have public health, so we had a healthy working class. That's why we do population health. It's got nothing to do with altruism and reducing health costs down the track, because most times it doesn't. It increases health costs. It's a macroeconomic phenomena. And in terms of population health, how do we increase the access to people to the health services they want? And finally, and most importantly, how do we reduce the costs of healthcare per capita and per intervention? Because if the health systems are to become sustainable and affordable, then we have to deal with both the care, health and cost outcomes simultaneously. So there's some questions for you to ponder. It's not quite the subject, that heading that I was given, but the reason why I've run this to you is that we are seeing things disrupt and we are seeing things change. Now the change is currently being driven by the technicians and the technologists. It's so important for us as healthcare providers and our communities to sit together and say, what do we want from this? What is our value proposition? What are our user requirements? And to shape the system so that it's not a system driven by technologists, but by a system driven by people who have a very clear idea of what they want from their health system.
Hi everyone, can you hear me? Oh yes, you can. Okay. So I'm a bit of a wandering minstrel, and when I heard that I didn't have to stand behind the podium, I was really happy because I'm a little bit vertically challenged and all you'd see is the talking head. So, like Des, I won't specifically speak to the topic that was asked of me, which is the perspectives of health professionals on innovative health systems. Well, first of all, that would be a massive amount of research. And I would argue that health professionals don't know what innovation they're being pushed into necessarily, or what's coming up the pipe. But what I will do is explore the general area from different points of view. So when you're thinking of innovation, you can look at it from different motivators or drivers. So Des spoke of the need to reduce or contain costs. I would argue that that is a public policy motivator. Governments are concerned about the sustainability of a system, especially in Canada where it is publicly funded and we only have a 30% share in the private market. So if you're looking at innovation, whether it's Monsieur Barrette in Quebec, who is government, imposing specific measures, you have to understand the mindset and the point of view. The second motivator is around access and timeliness. So that is the reason why Canada fares so poorly on the Commonwealth Fund scorecard. Access to healthcare in Canada is appalling. I'm the poster child of WAIT. It was actually quite good because there was a very cool idea by the federal government and the provincial ministers of health at one point to establish those wait time targets. We all remember those. And it was the season of hip and knees. And that occupied the time in the operating rooms, and if you happen to need an elbow or a shoulder fixed, you're out of luck. So when I was talking about the bubble effects of the public policy decisions that were being made on patient care, I had a lovely snapping elbow and they kept locking, and every time I talk about it and I talk with my hands, my elbow would lock and would snap in the microphone and I'd say case made. So, the innovation from a public policy or performance target certainly hit mixed reviews because unbeknownst to many, but a lot of docs want to work harder. We have actually done some work at the Royal College where we've studied, what motivates people, what discourages physicians, and so on. And the inability to provide quality, timely care is one of the biggest hits that you can have a physician face. They really hate having to make their patients wait. So if governments say these shall be the priorities and there are no concomitant resources to address the ill effects. So yes, the health professions may resent certain innovations that perhaps have some political motivators. Then, everybody wants to improve quality of care. And here's where the concept of co-development really works. So we've seen some very, very nice things being done, like choosing wisely, where health professionals work with patients to actually curtail ineffective use of testing and medications. So that is gaining momentum. And the nice thing is, it's not costing all that much. It could actually save money. So this is where something that's been co-developed, and that's a point that Des was making, the concept of bringing the parties together. It's also appealing to the payers because they are actually being able to account for reductions in necessary expenditures and utilization. But the other piece that we keep forgetting is that quality of care is also about things that matter to patients, as are wait times. Yet we, as patients, are very vulnerable to any effects we can have on the healthcare system. And the notion of public involvement in development of innovation in the interest of patients is very difficult. The palliative care movement in Canada has done quite well in that regard, where the voice of patients who have had family members who are involved in, who are themselves pursuing palliative treatments, actually have a voice to mold how the system's being developed. And they're small incremental innovations that are so meaningful to people. So are we looking for the big bang, or are we looking for things that matter? And it's all in a point of view. Now, if you are thinking of the provision of care, I keep reminding people that your care providers, your physicians, your doctors, your nurses, are people as well. And the criticisms that are leveled against the younger generations of not working as hard, whining about work-life balance and so on, is actually quite laudable. There is, mixed views in the literature around the benefits of a better work-life balance in terms of patient safety. But we know on the worker's safety, the ruling is clear. Driving home after 24, 36 hours makes you an unsafe driver. Aviation figured that out a long time ago. Whether or not it's unsafe or safe for the patient, let's think of the workers. And we know full well that better work-life balance also improves the quality of care that we receive, because a fulfilled, healthy clinician provides better outcomes, better care. So as we think of innovative models and things, let's think of all of the moving parts of the puzzle. And, if we look at, the concerns about the whiny younger people who don't want to work, organizations like the Royal College have actually taken this quite seriously and have co-led initiatives to develop fatigue risk management toolboxes. And we're actually going to integrate fatigue risk management in the accreditation standards for all of the medical and surgical specialties that we recognize, except for family medicine. Oh, and the beauty is that the accreditation standards for all medical training in Canada is harmonized. So we have an interest not only in our future physicians, but we also have an interest in the health outcomes of the patients that they serve. And by having better work-life balance, I would say that that is a huge innovation. But what is innovation? We don't know what innovation is. Des gave us some examples of putting things up in the cloud. But there are some smaller scale innovations. So e-consultations is, I think, a success story that is not yet celebrated in Canada and is so meritorious of scaling up. So we have year 2 now of a lovely collaborative project which is funded by Canada Health Infoway and the Canadian Foundation for Healthcare Innovation. And that hits every one of the drivers that I mentioned before. E-consultations will definitely save money because a lot of our rural and remote communities, we transport patients in. So it'll save money for the individuals who have to move themselves. And when we think of our Indigenous communities, government pays to bring them in. But if through an electronic consultation, and this isn't just building on telemedicine, this is actually timely point of care, we will have individuals be able to, let's say you're a family physician or a nurse practitioner. You can move ahead, contact a specialist, send labs, images, and whatever, and actually have a quick feedback on the clinical case that you're functioning with. And this feedback's normally within 48 hours. And then you can determine if you have to transport the patient. And in most settings, they've actually reduced the physical movement of a patient by 30% or more. I think that's a success story. So we're saving money, we're improving the quality of care and access to care because it's timely. It's helping the work-life balance of the clinician because they're actually being able to take care of the patient then and now and perhaps sleep at night. And I would hope that in terms of the wait times, we'll actually start collecting these success stories, and not because we want to do well for Commonwealth Fund report cards, but to actually be able to live with ourselves in terms of how we treat some of our rural and remote communities. The failure for me is we live in a land of pilots, and we all know that. And if we could bring and there are very few tables where we have payers, providers, and academics together. And if we can hit all of those motivators, maybe we can get folks to come together and move beyond pilots. I look at Ontario's foray into the innovation of introducing physician assistants in the province. There's no sustainable funding provision, yet we have clear evidence from the United States where they've had decades of history with what were their military medics. We have evidence in Canada of the advantages of reduced costs, better care, better access, better work-life balance with the introduction of physician assistants and some savings, but yet we're not moving ahead. So as future health leaders, I'm hoping that we can create opportunities to bring these disparate perspectives together. And for me, the biggest failure so far is we're at the beginning of the 4th industrial revolution. And what are we doing about it? When you say, what are the health professionals' views about innovations in healthcare? We have yet to try to conceive of what that could be. We're not adjusting the roles. We're not training our future health professionals to be adaptive. Their roles will change constantly. So if we look at radiology, I mean, just from a business intelligence point of view, I'm looking at the membership dues that the Royal College collects, and I thought, probably going to see fewer cardiac surgeons because their role is being subsumed by a bunch, and that is our doing because we define the scope of practice through education of the various specialists. So interventional radiology, check. They meet, societal health needs, they'll improve quality of care and so on. Well, that's a little bit of what the cardiac surgeon used to do. So they're going the way of the dodo bird, or their role will drastically change, and their numbers and distribution will change. Radiology is another discipline that will drastically change. And so will all of the lab medicine disciplines. So we're seeing a huge decrease right now in the number of pathologists in the country. Well, their roles are being subsumed by PhDs and to a certain degree starting to be by machines. And we're functioning at a far different level of technology and science that we did when we first defined the discipline. So the leadership role of the Royal College has been failing in terms of preparing tomorrow's physicians for the fourth industrial revolution and the changes that will come. So we're actually seriously going to start biting that bullet, and we're creating the Canadian way, a task force, but at least we'll get the conversation going. Des is laughing, yes. We've had, that's the Canadian response. Let's create a task force, but we actually try to do something with these things. So when you think of displacing health workers from a health leadership point of view, and the changing roles, what are we going to do? So the University of Toronto introduced AI into its oncological services, and what used to take 4 hours to plan a radiation therapy program for a patient now takes 2 to 4 minutes. So the physicist and the radiation therapist, time is going to be occupied differently. So how are we going to organize our systems, our healthcare services, and our workforce to function in an ever-evolving world that will hopefully provide better care and save money? So one of the fundamental things that we're not doing is when we're recruiting folks into our medical schools and nursing programs and so on, is to recruit people who will have adaptive skills, so that no matter what innovation is, they are okay with that change, and we have groomed them throughout their education to accept change. We're also not doing anything from a continuing professional development point of view to initiate people to change to this type of system change. And it's not necessarily, this is where I'll disagree with Des, and we don't disagree on much, but if you bring anybody into part of creating that change, docs will change. And when we look at what was announced today in the province of Quebec, as of today, advanced practice nurses with advanced training can initiate and continue treatment in 6 chronic disease domains: asthma, COPD, hyperthyroidism, hypertension, and so on. So family physicians, you would think, should be threatened, but they were actually part of the movement to create this new regulation, as was the regulatory body, le Collège des médecins du Québec, and the Federation of Specialists. And as a byproduct of these evolving roles, we've noticed over time that family physicians are increasingly specializing. So they're not interested in doing cradle to grave, and somebody else has to pick it up. So we're seeing a scaling up of different practice models, which are innovative in their own way, but they're not necessarily rationalized. So from a health leadership standpoint, how are we going to systematically measure the benefits of some of these public policy changes, the benefits or not of some of the innovations, because robotic surgery sounds really cool, but are we dehumanizing healthcare to a point where the patient is left orphan and dealing with someone who was not directly involved in directing the surgery? So if we are to build a system that saves money, that's one way to do it. But if we want to do it the Canadian way and not create a task force, let's think of the values that underpin our movements and our innovations. So I didn't answer the question at all about what health professionals feel about innovation, other than perhaps dismissing the idea that everyone is rigid in their guilds. But I'd be happy to answer any of your questions, and I will not apologize for not having answered the question, because it was rather difficult and I can't speak on behalf of the world. Thank you.
Des, Danielle, thanks so much for taking the time today, and a flight from New Zealand. That's impressive. A question actually on scale. Specifically, Danielle, you referenced the U of T oncology example of cutting surgery times. One of the problems in the Ontario health system isn't necessarily ideation of new innovation, it's in fact hitting scale. How do I get that U of T example in every oncology area in Ontario? Do you have some thoughts around how we facilitate that, or the conditions to get them right in Ontario to facilitate that scale, like the e-referral program that you referred to, which is starting to hit scale?
Well, there's something about Toronto being Toronto, which just gets different resources and other parts of the province doesn't. It is the provincial seat, and Toronto is the province's and sometimes the country's sweetheart. In terms of scaling up, I think that we would be surprised where technology is getting a foothold. So part of it is attractiveness of opportunity. Guelph, for example, is a bit of a hotbed of innovation as well. Perhaps not, well, in veterinary care, among other things. So it's not something that you could conceive of a logical plan for the country as a whole. For the province of Ontario, I think if it becomes of political interest, that can demonstrate savings. So the nice politics is we brought this thing in, we're getting, we've created new jobs, we're saving money doing it, and people are getting quicker and better care, then you've got a bit of a pitch. It's a bit of a difficult situation when you're thinking of doing it in Quebec, which is strapped for cash, and where you have a minister who has very strong ideas and a premier who's, and they're both physicians and are pretty locked down and alienating the profession, generally speaking.
I'll be very, very brief. By the way, the issue around saving money is not to save money, but it's to reduce the increase in cost to at least parallel with growth and wealth. The two examples I can give you of rapid scale, the characteristic of health systems is innovations don't spread. Left to their own devices, they don't even go across the road. The two examples I can give you where I've seen it spread is one we did in Australia where we mutualised the risk. In other words, we said to a group of providers, there's bonuses for you if you achieve a certain level of efficiency, but if any of you don't meet it, then none of you get the money. We mutualise the risk. We found an outbreak of innovation, sharing, collaboration and cooperation like you wouldn't believe, sharing resources, sharing people, sharing ideas, because we mutualised the risk. Behavioural Economics 101. The other is to, and this is something I was mentioning to the scholars I was talking about earlier today, you get innovation not by central agencies defining process. Central agencies should be process agnostic. You get innovation by providing provider alliances with both financial risk and outcome risk, which requires them to work with the consumers to develop what is a value proposition. So the way to actually generate widespread uptake of clever things is by shifting financial risk and outcome risk onto the provider groups. Now, both of those examples do work because I've seen them work on many occasions. If you're expecting altruism and goodwill to drive an outbreak of innovation, a spread of innovation, you won't see it. You simply won't see it. It's not my idea, I didn't invent it, I don't own it. So there are ways of doing it, but they are economic.
Thank you very much. Very insightful discussion this evening. Some really key points that came up in part of the EMBA, and one of the pieces, Des, you mentioned, was around the change in technology and technologists being the driving force in shaping system change. And that's extremely relevant, and we see that in the private sector with the Ubers or the Airbnbs that then shift policy changes after the technology's in place. And I know it's a big question, but where do we start in a world of healthcare where policy and regulation is so heavily weighted in order to change that sequence of events and for moving to rather a proactive approach to all of this innovative change rather than a reactive approach that we take in medicine?
Now, look, an outstanding question. The regulatory approach becomes sane when you move to competency-based or outcome-based regulation, not practitioner-based regulation. The first step is to get away defining roles by profession and start defining it by competency, experience and outcome. The concerns that people express about virtual systems around how do you regulate, it's got nothing to do with regulation actually, it's to do with the fact that a lot of my profession, a lot of your profession, is worried that in a virtual world we may not add value and we'll just drop out. It's a real challenge for you and me to define where we add value. But I mean, where you liberate regulation is by moving to competency and outcome-based regulation. The professions have always been more than happy to define practice and scope against disciplines because that maintains the marketplace. It's straight restrictive practice, and unfortunately the regulators play into the hands of that sort of process.
Hi, first of all I want to say thank you very much for your talk. I learned a lot. For me, I'm more in the technical aspect I'm more of a stats student and more of data science in particular. So one of the things that does bother us, the statisticians, the data scientists, is sometimes when we're looking at questions at improving the healthcare industry, there's always questions to reduce the cost or come up with new innovative ideas, but the data in and of itself is so vast. And you want us to be able to interpret in the correct way. Do you ever see any type of influence of the big data being able to influence how the healthcare is going to impact us moving forward? Because it's going to get bigger and bigger and bigger. Because I know you mentioned being adaptive. I think that's one of the things that's very important, especially for us as data scientists. What do the physicians want? What do they want to get from the data? That's one of the bigger questions that we just have a lot of problems with. So
I'll
one of your thoughts on that.
A very quick hand over to Danielle. I've just written, myself and a guy called Michael Kushner from the Department of Veterans Affairs in the US have just written a paper for academic medicine on big data analytics and how we need to have co-development with the analysts and physicians so that in fact they're providing mutually sustainable solutions which are understood by both sides. The truth is we're graduating doctors who can no more understand big data analytics than fly to the moon. And we've got guys like you developing big data analytics where a lot of the assumptions you're building into it from a clinical point of view might be quite spurious. So what we're talking about here is a deliberate co-development of big data which makes sense to all parties, where the assumptions make sense and where the consumers can actually use the data. You're talking about third-party data and insurance. The big data stuff which historically clinicians have refuted, have not used because they think that double-blind clinical randomised trial is the only way to actually manage information sources, and that's nonsense. So I've actually written on that, and in fact it goes exactly to the subject you're raising. But first of all, you flag there's a need. Secondly, it's got to become a core part of any curriculum.
Thank you. What scares me is we're relying just on the face value of the data. The data doesn't always tell the story. So I look at the example of emergency physicians. They tend to retire younger. And I was talking to somebody in government, and they said, well, we'll just assume that they're doing good financial planning and that they're exiting the workforce. Well, first of all, they're not necessarily exiting the workforce. And B, their life cycle's shorter because it's pretty tough being an emergency doc. So if we're going to be making decisions on the basis of the data, let's make sure we fully understand the data. So that's my first rant. My second rant is that we don't take health workforce research seriously in decision making. And if you look at the makeup of the departments of health in our various jurisdictions, there ain't that many people that have the smarts that we have in our universities. So if they won't staff up, they should establish better relationships with the think tanks and the smart people, such as those in this room.
Just want to say first, I think that was a really uplifting presentation from both of you folks. Maybe some just common grounds. I think one thing I hear from both the presenters, From your perspective, Des, you talked about the need for leadership in education for healthcare providers, and then I think from Danielle, you very similarly talked about the need for adaptive skills. One thing I feel actually challenged on that is I'm a practicing clinician. How do we address those that are currently in practice already, especially those that maybe just came from school versus we have a very big spectrum to those who've been practicing for 10 or 20 years. And any comments or any models you've seen out there trying to address those issues? Because when I think about that, like it's almost like, I'm not sure it's just an education. It's almost like a little bit of a mindset, like an attitude, but I'd love to hear your thoughts on that, actually.
Again, I'll try and be brief. The answer for people like you is through your continuing medical education, but one thing we know about CME is that doctors are attracted to areas which they already know a lot about. So it's how you direct them to areas they don't know about and are not comfortable operating in. So there is a requirement for a reaccreditation and recertification, which will go global, which will require you to do stuff you just are weak in, or where an issue has arisen after you've trained. What we can't rely on is self-directed CME to address shortcomings, because we know that does not happen. The other thing I think I'd mention around the sort of thing we're talking about here is that if you are genuinely agnostic about process, that innovative ability that exists. I mean, when I ran the National Health Board, I tried to get out of defining process. I think I've got thousands and thousands of the most spectacularly clever people out there who I am constraining by the way I'm funding them. If I fund them in a process agnostic way, let's see how smart they can get. And the answer is they can get very smart. You don't require courses in innovation, you just require an environment in which innovation makes sense. When you know what you need to achieve for me, for example, mental health schemes, we're running 6 of them now, where we fund mental health teams to keep people in work and living independently. Don't care how you do it. I want them in. Now, because when we talk to mental health patients, they said to us, I want to live independently, I want a job. When we then send to the funders, when do you get a return on investment in mental health? Is when they can live independently and get a job. Okay, terrific. Convergence of ambitions. So we said to the clinicians, that's what you're going to do. You're going to achieve levels of employment and independent living. Don't care how you do it. Well, the spectacular innovations that arose are quite extraordinary. Upskilling school nurses to identify kids in trouble, texting and other very, very cheap electronic measures of driving compliance. Very, very simple stuff. But it didn't require a course in innovation. It just required an environment in which innovation was actually in their interests. And the point I'm going to make last is that by getting that funding model right, getting the outcome risk and the financial risk, guess who the first group that those providers talk to? The consumers. How do I change your behaviour? What would you value? In return for what would you behave differently? What have I got to do to get you to take your damn pills? Something as simple as that. So I actually don't think you need courses in innovation. I think at the moment, innovation is almost killed dead by transactional funding. Why would you innovate when you're funded for a transaction? Just transact. You see the point I'm making?
So your specific question was, how do we help clinicians in practice adapt to change and innovation, correct? So first of all, do we know what innovation and change is coming up the pipe? So we have to be more mindful, and organizations like mine have to be more conscious of what tomorrow brings so that we can not only prepare tomorrow's docs for that reality, but support new docs or docs in practice. And we are process agnostic as well. We do needs assessments. And then based on those needs assessments, you develop an educational program. And we don't do much butts and seats type of education. It's pretty well asynchronous online. Our ebooks apparently really rock it. You can click on an image and then it comes alive and you see lungs moving and so on. So we have to adapt not only what we teach, but how we teach, so that we're respectful of the clinicians' life realities. So there is no answer or magic bullet, because we still have to try to get a noose around what that change is and what it might bring. So we'll have to talk to our friends in California and elsewhere who are pitching these ideas, and that quite a few of them are taking root. So there are health quality councils in different provinces are doing a great job. So in Saskatchewan, for example, when they instituted the system where you're not assigned to a referral goes to a pool and then it goes to a group of doctors. There were system changes that were required, accessing patient files and all of this nonsense. And the Quality Council actually sent teams into individual practices that were part of this new system. So that is just-in-time teaching, and they were not only working with the clinicians, but with the administrative staff and so on. It's an investment of time and money on both parties, those who are instituting the change and those who are embracing the change. But if we're serious about it, we have to do it well.
I had a question for Danielle specifically, and it's kind of around the theme that you mentioned about measuring outcomes. So how do we measure the benefits of scaling up healthcare systems in Canada? And you also talked about innovation, and it just seems like everything that you had mentioned seemed to be a top-down process. So I'm wondering, what is the role of the patient, specifically vulnerable populations, for example, in Southern Ontario, Indigenous populations in the Sioux Lookout Zone, for example? And I'm wondering, regarding the uptake of services as well. So it's great to have these innovations, and you're continuing to promote them and continuing to implement changes in the healthcare system. But what happens when there's no benefit from the uptake of these services? And exactly how do we measure that to ensure that we're not on this route of implementing innovation after innovation when it's not really benefiting those that have the least amount of access to the healthcare system to begin with, due to systemic inequalities that persist?
I think we're probably getting over our colonial habits of imposing ways, especially on Indigenous people. So when innovations are introduced, especially for our Indigenous peoples, these innovations or new ways of doing are co-developed. If they're not, they will fail and there will be no impact, or there will be a negative impact. And I think we have a new awareness. I mean, I was delighted to hear acknowledgement of the territorial lands on which we have the privilege of being today. And the Truth and Reconciliation Commission is starting to penetrate. So I'm not too worried about imposing a way of being. I think it's on our Indigenous peoples. I think there's a lot more mindfulness in that regard. What worries me is some of the changes that are being imposed in downtown Toronto or Ottawa, where I come from, where there has been limited public input. So this patient-centered healthcare for me is lovely rhetoric, but we have yet to do it well. The outcomes are often sterile, but it's nice to see that a lot of the tables in hospitals and so on have forms that patients can fill in about their impression of the care experience or ongoing follow-ups for health outcomes. So, not a surprise, I'm not only a broken elbow, but a busted hip. So I've had a hip replacement, and I get my periodic questionnaire on how I'm doing. So there are systematic ways of measuring outcomes, but they're not following my well-being. So it's not a perfect system by any stretch, but I don't think it's as malevolent as we might think it is.
Hi, thank you both for your talks. I just have a quick question for Dr. Gorman around sort of his point on sort of, I guess, the joke of having a double-blinded RCT for everything that needs to be validated. And given that McMaster, I guess, is the home of evidence-based medicine, and there's a huge investment into evidence-based policymaking, I'm curious to see your thoughts on sort of how this pursuit of creating a really robust evidence base can either help or stall sort of iterative innovation.
Yep.
It's a good question. The reason why evidence-based medicine was introduced was to reduce variability, to try and improve patient safety and improve outcomes, but it stifles innovation. It's also based on ephemeral truths. When I was a medical student in the early 70s, I was taught the brain was hardwired. You're born with a certain number of brain cells, and what you do doesn't change brain morphology. Both my doctorates are in brain injury research, and so I'm reasonably confident in saying that none of those things are true. What I was taught as truths were completely wrong. So that evidence-based medicine would suggest that it has a truth base is a nonsense. Medicine advances by opportunistic observation of outliers and pursuit of outliers. Now that needs to occur through appropriate informed consent, not completely surreptitious research. But we've got to be very careful that evidence-based medicine is not a straitjacket we're imposing on ourselves, that we're solving one problem of variability and killing another. And I come back to my point. When you create financial and outcome risk and you co-develop what valuable outcomes people think exists, you create an environment for innovation, and that you shouldn't be constraining yourself by way of process. So every time you write a rule about what the process has to look like, understand what you're doing. You're defining something in a point in time based on a series of facts you believe to be true today. How do you know what is working? Well, if you're purchasing outcomes, and I gave you an example before for mental health, when we said to people who have mental health issues, what would you value as an outcome? And they say, I want to live independently and get a job. If you then turn to government and say, when do you get a return on investment? Well, it's when they live independently. So you can actually find outcomes which matter. For example, for diabetics, it's living independently, it's employment, it's staying out of hospital and staying out of renal failure. So what outcomes would you purchase? That's what you'd purchase. What did the Brits do? They funded HbA1c levels. What did they get? Huge over-servicing of the already compliant diabetics. The costs went up, the activity went up, outcomes didn't change. So you need to understand that the outcomes you're purchasing are valuable, that the outcomes, they're co-developed, and then get out of the way of defining process. So evidence-based medicine, a bit like DSM 1, 2, 3, 4, 5, existed to put some order into the chaos that was psychiatry. What it's done, in fact, instead is create an environment for the pharmaceutical companies to market their drugs across a whole new raft of diagnoses like social avoidance syndrome, which I think means that someone's shy. So evidence-based medicine's a two-edged sword. Make sure you use it for the right reasons. But the most important thing for you, and this is true for both you in the data sense, we have to build into medical students and everyone else, health providers, an unbelievable scepticism about the truths on which today's practice is based. Because the truth is, half of what we teach you in 5 years' time would be wrong. We don't know what half it is. You know, I've heard this before. So how do you manage that level of unreliability of truth? Scepticism. Profound scepticism.
I'd just like to offer that I think we've moved beyond evidence-based medicine to evidence-informed medicine. Which doesn't replace, which allows clinical judgment to come in. And as we have, the advent of machine learning, the usual patterns that we've held as truths will be adapted and reinterpreted for us.
Des, you did touch on the one thing that I wanted to maybe have you elaborate on. We talk about innovation, we talk about new technology, et cetera, but essentially we're talking about a change management problem. I mean, if we never had one new thing in technology, we'd still have a crisis, and we still have an opportunity. I look at, I'm old enough that Medicare came in when I was young, and the doctors saw it as a great be-all, but largely because they thought they were going to make a lot of money, because they were going to have a payer. The dentists made a very good decision. They chose not to be involved, and dentists have gone on to make a lot more money than doctors do. It's because dentists have figured out how to differentiate labor and how to extract money and run big practices. To me, I look at this as a massive change management problem, and whenever I'm addressed with a problem like that, I look at rewards and punishments. And to me, throughout the whole healthcare system, there are few rewards and lots of punishments. Doctors work so hard, God bless them, like WorkLife Balance, A lot of them do that to make the money they need to pay off student debt and so on and so forth. The wait times in hospitals, I'm sure, are driven by the government as a brute force attempt to minimize cost, so that people will give up waiting in the emergency room and go home. Patients are rewarded by all kinds of excellent health care, but there are no rewards for taking care of yourself, good diet, or anything else. So just in that context, if you could wave your magic wands, what are some of the tweaks to the rewards and punishments that you would like to see governments, mostly, but also others, but primarily governments, change the rewards and punishments so that well-meaning people, doctors, other healthcare providers, and patients for that matter, would be incented to do the sensible, right behaviors and effectively change the system with no change in technology?
Yeah. Some very good questions. I'll go to the last one first. One of the things we have managed in the New Zealand environment during my time with the National Health Board is 99% of anyone presenting to ED is out of the place in 4 hours, either discharged, treated or admitted. And we did that by providing a financial top-up to them, but then putting money at risk. And we had paired targets. One was elective surgery and one was ED. So there couldn't be resource shifting. So we had an elective target and an acute target, topped up the budget, but then said, let's say we gave you 5% more, but then we said, if you don't hit the target, you're going to lose 10%. And we said, all the hospitals in your region, if they don't, that's mutualising risk I said about. So within 6 months, every single hospital in the country was hitting its ED targets because we mutualised the risk. Behavioural Economics 101. The answer to your question about remuneration, there are 3 ways in which you can approach remuneration. One is to get a bunch of clever people in a central bureaucracy to try and work out whether you're going to salary the doctors or you're going to pay a fee for service or you're going to capitate it. You can generally assume within 5 years it will be completely corrupted. People will have learnt to game it in such a way as that it's corrupted. Then, so what some people say is, well, what we'll do is we'll introduce a system, we'll keep it 5 years, then toss it out and start again. That's things like Cisco Systems, they say, well, here's a funding model. In 5 years' time, the clever buggers will have corrupted it, let's get rid of it. The second approach, which is slightly less unclever, is to say, no, we're going to get a bunch of poachers in here, providers, turn them into gamekeepers and help us design a system which is poacher-proof, and we're going to try and protect it from being corrupted by compliance audits. They corrupt in 6 years instead of 5 years. But these people are clever. This is the way you do it. You say, this is going to be gamed, so let's create a system which is designed to be gamed, but where the gaming benefits both the provider, the funder, and the consumer. Let's deliberately, and that's called tight, loose, tight funding, where you're tight about what you want, tight about how you measure it, but completely loose about process. It's also about commissioning. What's the counterfactual? What's the cost of business as usual? What's the actuarial determination of what you need to invest to beat the counterfactual? And create the system in a way, so we're going to create a system that's designed to be gamed, but where the gaming will actually be a win for me and a win for you. It's puerile to try and continue to construct systems which are restrictive or oppressive. So the answer is you create a system deliberately for it to be manipulated by the users, but where you're saying, we both have to win from this, you and me and your consumers. Does that make sense? It's a different approach, but the historical approach you described, well, that's just horse and buggy thinking, isn't it?
I've always felt one of the possible solutions is a mix of private and public.
Yeah.
In fact, there's a very interesting study going on in Saskatchewan right now where they're allowing private MRIs, but they have to offer so many in the public system.
Yeah.
To me, the only major reason that's not happening is the politicians lack the courage to address that sacred cow.
Yeah, I do. I have the advice I have is you have to get over yourselves. You don't have to have one solution fits all situations. You're not. I mean, the thing about funding models is that in some areas you use a capitation, in some areas you use activity funding, in some areas you use a bonus system. What would make you think, as a country, that you're going to have a single funding model to apply to everything? For example, in mental health, the last thing you want to do is do it on activity. You're kidding. It's lifelong disease. And if you looked at the sort of innovation I was talking about, where you upskill school nurses to recognise kids in distress before they self-harm or become bulimic or become anorexic, and the school nurse is not trained as a psychologist but is trained to have a conversation with a kid to identify where there are issues and then direct them to where they need to be. That sort of innovation doesn't work with activity-based funding. So there's some areas like chronic disease where you want to fund against outcomes like independence and employment. But if you take two mature markets in Canada, orthopaedic surgery and ophthalmology, use the marketplace. What we did, for example, in New South Wales when I was doing the reforms there, and in Queensland, there was a huge backlog of cataract surgery needed. Cataract surgery has high intrinsic value in an otherwise independent older person who can't drive because of their visual impairment. It's got a very high value. So we went to the ophthalmology marketplace and said, look, there's lots of you guys, you'd each your own young, so we want you to do exactly that. We want you to register that you're a legitimate ophthalmologist. Now, how many eyes will you give us for a $5 million? Now, the price went from $4,200 down to $1,400 per eye. So we got the entire marketplace, we got the marketplace to drive high throughput. Now, the following year when we were renegotiating their contracts, guess what they couldn't tell us? That the cost price is $4,200. We know what the cost price is now, it's $1,400. We've established that. So there's an example of where, if you have a mature market and lots of competent providers, you can use a marketplace dynamic to actually achieve wonderful efficiencies. But don't pretend that that market model would work for diabetes, because that's ridiculous. So I think the answer to your question is you need a toolkit, not a tool when it comes to health funding. But Canada needs to get over itself and actually look where the private model, and that's where you have piecework that has high intrinsic value. This woman had a hip joint replacement, she told you, high intrinsic value. Cataract surgery, high intrinsic value. You don't need to do outcomes. The procedure has high intrinsic value, though. I would fund mobility, not the surgery, if you know what I mean. I would fund the team to produce me a mobile person. I wouldn't pay them for the hip joint replacement. You understand the difference?
I can not only work, I can dance. So you mentioned the stick approach. If we think of carrots, so there was a cardiac group in one of the larger hospitals in proximity of this city that was going to the hospital vice president looking for more resources. Wanted more staff, more equipment. The answer was, if you can find money, you get to keep it. So they instituted a number of measures, including reducing wastage, and they saved $1 million in just over a year. And they hired staff and equipment, and they own the innovation, they benefit from the innovation, but I would say ultimately the patients do. In terms of the public-private, if we can crack that holy grail, it would be wonderful. Again, Quebec, bit of a disturbance, it's an agent provocateur. They have private MRIs. I brought my daughter there. We needed a quick diagnosis, gave my credit card, got the bill, sent it to my insurance. So they access private health care a lot more readily. And the province actually encourages it more because they are in dire financial straits. So I think as sustainability of the current approach to the system might just loosen up the reluctance to allow practitioners to be a bit more creative in how they give patients access. Because if you poll of Canadians, a number would say sure they'd pay if they could have quicker access. And if we ensure that we have a proper supply to meet those who are within the public system, it'd be quite a feasible and lovely solution to a lot of the backlogs we have.
So that was a great discussion. Thank you to everybody who asked questions, and thank you for very thorough responses. We're very grateful to have you here today, and we very much appreciate you coming, and especially all the way from Ottawa and New Zealand. So if you can join me in giving them a warm welcome and thank you. So at this point in time, we can take a short break. Why don't we reconvene in about 10 minutes, and then we'll proceed into the think tank. Thanks, guys.